Well, good afternoon. My name is Jill Canales, and I am here to help facilitate the breakout session on metastasis to the bone. And I am thrilled and honored to be able to introduce your panel for this breakout session. I'm going to turn it over to Susan Bavlov, who I've known for several years. And she will go ahead and introduce the physicians for you. So everybody has index cards. If you have questions, I'll be kind of circulating the room. So after the physicians have presented, if you have questions that are kind of general in nature that would be helpful for everybody to learn more about, we can collect those. And any questions that may not be asked or answered today, we're going to collect and have answered for you in the future. So I'm going to turn it over to Susan, and she can tell you a little bit about herself and tell you about the doctors.
Well, my name is Susan Bavlov, as she said, and I am an 8+ year thriver with metastatic breast cancer to bone. I was first, can you hear me? I was first diagnosed in 2002 with early stage cancer, went through the normal treatments and thought I was one and done. Then in 2010, based on some testing, it was discovered it was back. I got that phone call. It's back, and it's stage 4 metastatic breast cancer to bone. I call it thriving. A lot of us do. Some women don't particularly like the word fighting, but I think it is a battle. It is a battle to take. I've been through numerous different protocols of treatment, but as you can see, I still stand here. I enjoy life. I'm very thankful to be here. I spend a lot of time with family and friends. I do a lot of traveling. In May, I'm going on a trip to Europe, which is our probably 4th trip to Europe since I've been diagnosed. So I don't let it get me down. Now, I may collapse in between trips and just chill out for a while, but it's all doable. One of the things I did learn early on is that metastatic breast cancer is a marathon, not a sprint. It's not curable, but it is treatable. And it's like a chronic disease, like arthritis or diabetes. So that helps you understand kind of where the thought process goes. I'm very excited about this conference being here today, and that the Komen organization is now recognizing metastatic breast cancer as a separate, yes. We have different needs. That's not to overshadow any other types of breast cancer, but we do have our own needs. I think it's very important to have a team of your own doctors, a breast oncologist team, if you have to have surgery, one that's connected with that, and as well as your family doctor that understands what's going on, because your oncologist is not going to treat other things. So you have to have your own team of doctors around you. I am one that spends a lot of time advocating for my own health. When our speaker at the beginning talked about, show the picture of her charts, I don't have those charts, but I have Excel spreadsheets with every doctor's appointment, every PET scan I've had. I have copies of all my different tests and scans, some of it just for my own personal comfort, and some because we've referred back to them on occasion. But enough about that. We're here to hear these two experts speak, but I just want to say that I feel I'm resilient, and over 8 years later, it's still a marathon, but I'm here and I'm thriving. And now we have these two wonderful doctors here. Dr. Wade Smith is a specialist in the treatment of breast cancer, as well as benign and malignant blood disorders. He has been an investigator on several studies, in addition to his publication credits in critical reviews in hematology oncology and seminars in oncology. He is an active member of the American Association of Oncology, American Society of Hematology, and the American College of Physicians. Woo. And he's a nice guy. I know him. Dr. Kujak has a strong interest in oncologic imaging and has participated on multiple tumor boards and in clinical trials. She has spoken at numerous local and national meetings presenting cancer imaging lectures. Due to her keen interest in sports medicine and musculoskeletal fellowship, she is primary radiologist for the NFL team, the Los Angeles Rams. Yay! Rams. Uh-oh.
There we go. How's that? I like to walk. Okay, so as Susan pointed out, I think it's really good to have a really good medical oncologist. It's good to have a family practitioner, but you also need a really good radiologist who understands cancer and can help your medical oncologist and family practice doctor find the cancer sooner and kind of give them information about imaging and what can do next. So we can actually be your best friend. So today, here's what I'm going to talk about. I'm going to talk about what's a diagnostic radiologist, because I think a lot of people don't know what I do and who I am. Why do we image breast cancer? Because we don't image everything. How do we do it? How do we image it? How do we image metastatic disease? What types of bone mets are there? Because there's two different types of bone metastases that we see in every woman with metastatic breast cancer to the bone. And then how do these exams help me live longer and better? And then, of course, which test should I do for bone mets? Okay. So a diagnostic radiologist is a doctor. We go to med school, you get a college degree, you go to med school, you do an internship, and then there's a diagnostic radiology residency where we learn all the anatomy and how we image every part of the body, whether it's cancer or musculoskeletal like the Rams or whatever, and then you can do an optional fellowship as well. We're kind of the behind-the-scenes doctor, so we're in the dark room looking at the images and kind of helping out your medical oncologist make decisions about whether the treatment's working or what type of treatment needs to be used. So we're the imaging expert is what we are. So why do we image breast cancer? Well, there's a lot of different questions that we can get, that we can answer for you. We can find out if you even have cancer, which is, of course, screening and diagnosis. If you have cancer, where's the best place to biopsy? If the cancer comes back, where's the best place to biopsy to figure out what type of cancer came back? Because as you know, when you have breast cancer, you may be diagnosed with one type of breast cancer, maybe 10 years later you might develop a different type. So having that biopsy is important, and it really is important to decide where to biopsy so you have the best result. You also find out if and how far the cancer is spread. So as Susan pointed out, she initially was early stage years ago and then came back metastatic years later. So the imaging really determines whether you're metastatic when you first show up or if it's coming back. And then what type of treatment do you need? If it's one spot, maybe the oncologist will decide to radiate it or give different types of treatment. And then also determine whether all this treatment that you're doing, is it working or not? So that's kind of what my job is to kind of help them kind of be their assistant in treating you. Okay. So for diagnostic radiology, there's different ways we can look at how things are working in your body. One thing we can do is just anatomy. Is it getting bigger? Is it getting smaller? Is it changing shape? Is it less solid? Is it so that's the anatomy part. And then those things that we do anatomy are x-rays or radiology or radiographs. So like an x-ray of the bones or your chest. Ultrasound also looks for the anatomy of it. It doesn't necessarily tell me how it's functioning, but it does tell me if it's growing or getting smaller or bigger, changing shape. CT, of course, that just looks at anatomy as well. So whether something's bigger or smaller, do you have new things in new places? And MRI is completely anatomy as well. So that's just looking at, whether the tumor is coming back or not coming back, or do you have a fracture, do you not have a fracture, those things. So the other side of the coin that we do is physiology. So we're like how your body is working, how the cancer is working. Is it alive? Is the cancer growing? Or did the chemo kill it? Or the immunotherapy, destroy the cancer? And so that's where nuclear medicine studies, like a whole body bone scan for bone mets, looks at that. And then also the PET CT studies, that we were talking about earlier, that determines whether, the cancer is alive, growing, or not. Okay. So there's different types of bone mets that we see on imaging. And of course, it depends on the type of cancer that you have, type of breast cancer that you have, and where it is in the stage of the cancer. But there's two things that we look for. There's lytic metastases, which is the tumor goes into the bone and replaces normal bone. That's called a lytic lesion, and it's kind of see-through. So it destroys the bone, it replaces normal tissue. And so lytic is when tumor replaces the bone. Those type of metastases are best seen on MRI and PET. So I'll go into kind of what those look like. And then sclerotic metastases, those lay down bones and they become like a white spot on a CT study. So those are best seen on a CT scan, or you can do it on a bone scan. We see those types. So depending on the type of bone met you have, your oncologist may choose which type of imaging to do. And so I get phone calls on this all the time about, like, this is what I'm worried about. What's the best test for this patient? And this will be different between patient and patient and patient. It will be all different. So we'll kind of go over that together. Okay. So X-rays, radiographs, are they good for bone mets? Well, they're pretty good. They're not the best, but they're okay. And as you can see here, you can get it for chest. You can get a chest X-ray, look for ribs, okay, and you can look at the thoracic spine. But a lot of times, if they're small, we won't see them. But you can look on the cervical spine radiograph here. You can see there's pieces of bone missing here, so that kind of helps us determine whether there's bone mets or not. And this kind of bone met is a lytic. So you can, it replaces the bone, so it's see-through, if that makes sense. So ultrasound, can we use ultrasound to find bone mets? No. Unfortunately, ultrasound is really good for soft tissues. It's good for biopsying. It's good for diagnosing the cancer at the initial diagnosis, and it's also really good at picking up if it's recurred or not, which is why you come in for a diagnostic mammogram and ultrasound usually. And then if you have some kind of mass that has come back, it's much easier to biopsy it under ultrasound, and it's better for you to have it under ultrasound because it's real time and it's simpler. But it doesn't look for bones. So ultrasound, it's a sound wave, so it can't go through your bones. So we can't pick up bone mets with an ultrasound. What about mammograms? Can we see bone mets on mammograms? So when you come in for your screening and diagnostic mammograms, can we see them? Nope, because we're not imaging them. But they're really good at looking at whether your cancer is coming back or not. But there's no, as you can see here on your mammogram, there's no bones anywhere on that picture, so we can't find the bone mets that way. Okay. And then, of course, 3D mammos, you probably have heard of that. This is really good for people with dense breasts, and you can pick up breast cancer sooner. But again, no bones in this picture at all. What about if you come in for breast MRI? Can you see them? Occasionally you can. So when we image the breasts, we get the sternum, and occasionally we'll get the thoracic spine. So occasionally we'll pick up a bone met this way. But most of the time, breast cancer is really just to look at the breast itself, and then of course the axilla. But occasionally when you come in for a breast MRI, sometimes we can pick it up, but it's not really a good tool to pick up and screen for bone mets. And so here I'm just showing a picture of what a normal breast looks like on an MRI. And then you can see here's the cancer coming back. All right. What about an MRI of the spine? MRI of the spine is actually really, really good for picking up bone mets if you know you have them. It's not really a great screening tool because it's a long exam, so we'd have to screen your whole body. So you'd be in the MRI scanner for like an hour. So, but if you think you have bone mets or the doctor suspects you have bone mets, the MRI is really sensitive. And this is really, really, really good for those lytic mets that I was talking about, where the tumor goes into the marrow and replaces it. So here you can see a picture of it and see that dark spot there in here. That's the tumor inside the inside the vertebral body. And it will show up as edema or fluid on the this is a fluid sequence. This also is really good to determine, let's say you get radiation therapy to this area. This will also be really good for determining whether the radiation therapy worked or not. It also helps the radiation oncologist and medical oncologist determine, what type of treatment to do. Okay. And then CT. Is CT good for bone mets? It can be, especially if they're sclerotic. Here's the sclerotic bone mets I was talking about. See the white throughout there? It's good for sclerotic mets. For lytic mets, the mets that permeate, go through the marrow, a lot of times you won't see them on here. So CT is actually really good at looking at the visceral organs and the lungs. So like here, it shows like a lung nodule here. And then we just happen to be able to see the bone mets. Occasionally we can see them. And then a bone scan. I'm sure people have had bone scans before. This uses a radioactive substance that goes into your bones, and if the tumor is in the bone and causing a reaction around it, it will light up on the bone scan. So it's really good for those sclerotic mets I just showed you. And so you can see here's where the bone mets are, so your doctor knows exactly where they are. And here's what someone without bone mets looks like. So all these black spots kind of light up. Okay, so I'm going to spend the next part of my talk talking about PET-CT imaging, because I know you guys have had these studies and maybe don't know how they work, so I'm going to talk about that, and then how good are they at picking up bone mets. Okay, so FDG PET-CT study. So PET-CT study is using a radio tracer to pick up tumors in the cell. FDG is a glucose, so there's all kinds of PET-CT studies out there, and more are coming on the market. So hopefully someday we'll have a type of PET scan that targets only breast cancer, which will be really nice. So FDG is basically glucose, so it picks up anything that uses glucose. And so it's a radioactive substance that uses glucose to grow and live. And so it's good for anything that uses glucose to grow. And it's good for lytic mets. And sometimes you can see the sclerotic ones as well. But the cancers like lobular carcinoma, that type of breast cancer, can be really tricky against all imaging. So this that's a really sneaky one. So on FDG PET, it may not light up as much. And then MR, you may see it there, and you might see it on mammograms. So how does the FDG PET work? So when you come in, you're laying down, and we inject you with something. What are we injecting you with, and why are we doing that? Well, it's a radioactive glucose, and so we inject it into your vein, and we wait 45 minutes. And what we're waiting for is this: the FDG is floating through your veins, and tumors any cell that uses glucose to grow has a receptor on it that called GLUT1, which is a glucose receptor, and it pulls all glucose into its cell. So most cancers use glucose to grow and take it from other cells, and they take it directly from your bloodstream. So what happens when you come in for a PET scan, if your cancer has come back or you have cancer, all this stuff will accumulate into the cancer cells and light up on a PET scan. But it is important to know that if they don't have this receptor, if the cancer does not have that receptor, it won't light up on a FDG PET, which is what I was telling you about with lobular. lobular may not have a whole bunch of GLUT1 receptors on it, so it doesn't light up on an FDG PET. Someday, though, we'll come up with a different type of tracer that will be targeted to lobular cancer so we can pick it up sooner. Here's what a PET scanner is, as you know. And here's the fine print for the nerds in the crowd, if you want to read this while I'm doing this. Here's the F18. You have a positron. You have this negative agent floating around in the cell of the cancer cell. And it emits gamma radiation, which is picked up by the salt crystal, which to me is like magic. It's kind of, I don't understand how they even came up with this, but it started in 1933, and now we have it. So it's amazing the type of things that have come this far. So here's kind of a see-through PET scanner, just so you know when you're in the PET scanner what's going on. There's a CT scanner, and here's the salt crystal I was talking about. So when you're lying in there, what we do is we do the CT part and make a CT image, and then we acquire all the radiation coming off of you from your body. And it's actually you giving radiation to us in the machine that makes the image. We're not giving radiation to you. I mean, besides when we inject it into your vein. So, besides that. But besides that little part. But when you're sitting in the scanner, everybody wonders, is that like a radiation thing that's radiating me as I'm sitting here? We've already given you the radiation, and you're actually giving it off. So you don't get extra radiation when you're in there. So, and that's kind of what the fused images look like. Okay. So we torture you with the FDG PET and ask you to do all this stuff. Why? Because we're mean? But we actually do it because we want to make sure we can pick up the cancer the best we can for you. And so we ask you to not, work out. And that's because when you work out, your muscles use more glucose the next day. And so all that radioactive glucose will go into your muscle and not the tumor cells. So we'll miss it. Why do we ask you to do this? The protein, veggie, so you don't have, your glucose isn't really high in your bloodstream when you show up. So all these instructions, it's really important to bring them. And then people ask me all the time, can I take a pain medication? Can I take Valium? Actually, it's completely fine. All those medications actually are really fine. And some people do quite well when they take some type of anti-anxiety medication, because when you're anxious, we have fat in our body called brown fat. And so when we get anxious, it makes that brown fat work, and that uses glucose, and so you'll have uptake in normal fat, which you don't want. So, but of course you can't drive after. All right, so here's somebody who did not prepare, did not listen to us. They thought that we were torturing them. And as you can see here, they didn't fast because their heart is lighting up. And so what I think is, you can't lie to radiologists, by the way, because we always know. We know, we can see inside you. So I can always tell when someone's lying to me, but on pictures. But here you can see there's tons of uptake in the muscles. This is all muscle and heart. So I know not only did they cheat on their diet, they ate before they showed up, and their glucose is super high, so they're probably diabetic too and didn't know that. And then also they worked out the day before. So this scan is not good. So here they came back. The glucose was fine. They didn't work out. And here you can see, here's where the cancer is, and here's these dark spots. We cannot see it on this scan, so we would miss it, completely miss it. So this preparation is really important. And here's the arrows to prove it. All right. So I'm going to end with one of my newest favorite patients, not because she has the same name as me. It's not me. She has Jennifer Lynn. That's her first name. She's 45. She has mother of twins that are the same age as my kids. And she showed up to our office with poorly differentiated invasive ductal carcinoma of the right breast, and I read her first PET CT study. She Not all radiologists do this, but occasionally I have patients that come in and want to go over their imaging with me, which I do all the time. But if the oncologist allows me to do it. But she had a very large breast cancer with lymph node metastases and bone mets at initial presentation. And here's a PET scan where you can see here's her breast cancer, this dark spot here. That's the nodal mets. And then you can see these dark spots here are the bone mets. Okay. Here's what her PET looked like at the beginning. So you can see here's her breast cancer. This big bright spot right here is a bone met. And here's another met in the sacrum. And she breeds horses for a living. So she had been hurting for a while and she kind of blew it off. But this is kind of how she presented. The oncologist treated her with these medications here, which I know Dr. Smith will talk a lot about. And she came back to me, and I'm still tickled about this, as she had a complete response to the medication. So you can see how the PET really helps with that. We know that it treated all the cancer. There's not any left on imaging. And what we also know is that all the cancer is the same and was treated. So sometimes we can be fooled in that this type of cancer, once it spreads to bone, may turn into a different type of breast cancer, and the treatment that you're on may not be working for that one. So she came back in complete response, and you can see here before and after. And here, it was lytic to begin with, and when it's treated, the body will lay down bone, and it will become sclerotic. So she's back to riding her horses, which is good. So super exciting. So in conclusion, many tests are available to you. Best thing to do is to talk to your oncologist and talk to who's taking care of you to come up with that. They can call me and talk to me about what I think. And choose a good radiologist, because you need someone who knows what they're looking at and does oncology for a living. And of course, radiology, all the cool kids are doing it. And then I put this in here because, as we were talking about before, with insurance coverage, it's been really bad. It's been so hard. This is a guy going through the TSA x-ray machine. My insurance won't pay for an MRI. All right, you guys, that's it. Okay.
Again, my name is Dr. Wade Smith, and I'm a medical oncologist. I'm a breast-dedicated medical oncologist. So I see and treat patients at all various points in time with respect to their breast cancer diagnosis. I even facilitate risk assessment for patients who are at high risk with a family history, for instance. But yes, I treat patients who come with early stage, resectable, curative breast cancer, all the way through to patients who have metastatic breast cancer involving bone, other areas of the body. And just as we learned in our introduction, this is a marathon. This is really, I think the treatment paradigm has changed considerably in the last 15 years, but particularly in the last 5 years, to where we are allowing patients to live longer and longer with well-managed metastatic disease, enabling them to have really exceptional quality of life, remain active, and we are kind of transforming this into a kind of a chronic illness or chronic condition type paradigm, similar to a lot of autoimmune diseases that require disease-modifying drugs and so forth. So that's the way we're approaching this conceptually. And I'm happy to give the talk on bone involvement with regard to metastatic breast cancer, and I think it's very befitting we have a radiologist combined with the talk, because when we talk about bone-only breast cancer, this is typically, we see it as a subset of patients who do well, who were able to achieve complete responses in a good percentage of patients, and are able to stave off using more toxic chemotherapy medicines for sometimes several years out because of the several lines of endocrine therapies that we have at our disposal. But again, many patients present with mixed metastatic disease, bone, including visceral, sometimes brain, central nervous system involvement. So I think it's helpful to look at bone metastatic disease as its own kind of subcategory. We treat it very similar whether we're talking about bone-only disease or patients who come with multiple sites of metastatic breast cancer. And so there are different therapeutic approaches to bone-involved metastatic breast cancer. And I think the cornerstone, as I mentioned, is systemic therapy, getting on top of the cancer globally, treating it with either endocrine therapy or immune-based therapy or chemotherapy, and also serving the benefit of systemic control and preventing the development of visceral metastasis for as long as we can. And so, in addition to systemic therapy using endocrine therapy, chemotherapy, a major category of medicines we use are osteoclast inhibitors. And I'll talk a little bit about osteoclasts. Within the bone microenvironment, we have mainly two different cell players that are involved in bone remodeling. Osteoclasts that resorb the bone and osteoblasts that lay down the bone. And understanding this dynamic has a lot to do with understanding how to control metastatic breast cancer that's spread to the bone, because we see that the breast cancer cells and the bone microenvironment have a very complex interplay in terms of protein, cytokine mediators, and so forth that really represents the focus of how we use targeted agents. Surgical intervention is oftentimes implemented, particularly if we have an unstable bone involvement with tumor. We have a impending tumor-related fracture or pathologic fracture, and so we'll talk a little bit about that. Sometimes people ask about curative surgical resection of bone. There have been some limited studies looking at what we call iso or oligometastatic disease to say, the breastbone, the sternum, or sometimes to the vertebra. And for the most part, we don't pursue aggressively surgical resection of bone lesions, with the exception of very few cases, partly because of the morbidity involved, if you can imagine. Plus, we have great systemic therapy to help control the disease overall. And then radiation therapy really kind of goes hand in hand with surgical intervention. So, and I'll kind of talk about how, but if you can imagine the importance of stabilizing a bone first with surgery, either placing a rod or other fixation, and then following that up with radiation so as to control the tumor locally in order to preserve the fixation. And then pain management is central, I think, in metastatic breast cancer management in general. And there are some kind of caveats and considerations to bone involvement that we'll talk about. So how do breast cancer cells spread to the bone? It's kind of in a four-step, multi-step process. First, you have colonization, and this can occur very early on, sometimes with first presentation of breast cancer. You have circulating cancer cells. They enter the bone marrow compartment, and they sit there. And they enter into the kind of the second phase, which is survival and dormancy, where cancer cells learn to kind of adapt to the milieu, the microenvironment. They learn to evade the immune system, and they can remain in this period of dormancy for several years. Then, at some point, reactivation and development occurs, where they emerge from the dormant state, and they actively proliferate within the bone marrow compartment, and they start to form scattered tumor deposits at this point in time, too early to pick up on imaging, and then enter the fourth phase where they become independent of the microenvironment. And I'll show you a slide as to how they become kind of, I would say interdependent, but at the same time, still very engaged with the bone marrow stroma and microenvironment, which kind of commandeers the signaling. And you can kind of get an idea here. You have breast cancer cells that essentially release these proteins these cytokines that have an effect on the osteoclasts. And again, when I talked about osteoclasts and osteoblasts, osteoclasts kind of remove the bone, the osteoblasts lay down new bone, and that's normal, healthy bone remodeling. But how breast cancer cells interact with the bone, they primarily engage with the osteoclasts. And this is kind of the setup for what we describe as osteolytic lesions that we talked about earlier. They basically erode the bone and create holes. And not only that, these osteoclasts create or basically allow for the release of growth factors to be released from the bone and further stimulate the cancer cells. So it's this kind of what's called a vicious cycle, continuous loop. And so, we look at what medicines can be involved to interrupt this kind of continuous signaling. And that gets to the osteoclast inhibitor category of drugs that we use. And this just kind of highlights how even within the same patient, we see osteolytic lesions with this bone removal, kind of what we see with a hole in the bone. But then at the same time, we can see osteoblastic lesions too. And that's kind of unique to breast cancer because, yes, it can create this osteolytic disease pattern, but it can also create an osteoblastic pattern that, for instance, we see with other type of cancers. 80% of breast cancer bone lesions we see are osteolytic, activating the osteoclasts. About 20% or so are osteoblastic. And in reference, you can see the classic osteolytic other tumors that we see and treat. Multiple myeloma is a very common one. Kidney cancer, a common one. And melanoma, when it goes to the bone, is a common one. With the osteoblastic lesions that are more breast cancer cells stimulating the osteoblasts that lay bone, that's shared in common with prostate cancer. And then you have this kind of, within the Venn diagram, you have this overlap category where we see breast cancer, but primarily osteolytic. We can see lung cancer, although small cell lung cancer often is blastic, as is Hodgkin lymphoma. And then, gastrointestinal cancers can also be mixed. So we can see both. And I would say, for the most part, though, we treat breast cancers kind of with the osteolytic treatment rationale in mind. So what's very important treating patients with breast cancer spread to bone is really monitoring and managing them closely. Because as I said, patients with bone-only disease, these are patients who typically do well. However, progression can occur, and thus the need for really timely follow-up imaging so that we can see that what we're doing, particularly when we're giving systemic therapy, is working. We want the disease to remain controlled. We don't want to be forced into a situation where we have to, for instance, interrupt our systemic therapy to implement surgery or radiation if we can avoid it. And so, this just kind of goes over how we classify these responses and essentially complete response. Obviously, we see no cancer at the time of imaging. A partial response, we see about a 50% or better decrease in tumor burden. And then there's obviously no change. I think the important thing to know is when we're treating bone-involved breast cancer, we want to give it some time to see that our systemic therapy is working. We want to, ideally give it 8 weeks before we draw any conclusion because the treatment response can be slower. And then obviously progressive disease, we need to change course. So our overall, objectives have to do with staving off or managing the complications of bone-involved breast cancer. And our key priorities are pain, controlling pain obviously, and then improving performance status is a common complication. So performance status is a priority, along with obviously quality of life implied. And there's a term we use called skeletal related events. And so when we do studies, this is kind of a way to see is treatment A better than treatment B by a more prolonged period of time before we run into one of these kinds of complications that I've talked about. And so such as a skeletal related event would be all of a sudden we now need to do surgery or radiation, or all of a sudden we now see a tumor related fracture or pathologic fracture. A spinal cord compression, which is a cancer emergency, is a SRE, and high blood calcium, which is also a cancer emergency that requires emergent attention. And so, getting to kind of systemic therapy, when we talk about bone-only breast cancer, the majority of the time we're talking about a subset of breast cancer we see most commonly that tends to be more easily managed early on, and we get kind of more mileage from the first and second line of therapies that we employ. And so a couple things can be said. One is when we see a breast cancer on presentation that involves bone or lymph nodes, these patients tend to have a longer survival before progression compared to those who have liver or lung, as a lot of us have an understanding. So also we know that breast cancer that is hormone receptor positive, again, this is the subtype we see most often with bone-only involvement, and we know that when we see estrogen receptor strongly expressed and we see the progesterone receptor strongly expressed, these are patients that tend to have an associated improved survival compared to, for instance, patients who are triple negative. And that gets to kind of how we manage from a systemic standpoint. For hormone receptor positive breast cancer, as some of you may be familiar with, we have at our disposal now a combination endocrine therapies that enable us to prolong the amount of time until we see progression, 10 months or greater. And ones that we're using more commonly now are the class of medicine called aromatase inhibitor, along with a CDK4/6 inhibitor, and I'll show you how that works, as well as fulvestrant or Faslodex, given alone or in combination with a CDK4/6 inhibitor. And when we look at it, here we have estrogen receptors that couple up, and these are within the cell. And the way that a breast cancer cell is stimulated to reproduce, estrogen will come along and will bind to each of these estrogen receptor that are bound together, and then they come down and they then bind to this estrogen response element, and that then activates genes within the cancer cell that tells the cell to divide. And that's the driver behind estrogen-sensitive breast cancers. And so the treatment rationale behind the drugs I've mentioned, for instance, the fulvestrant or Faslodex, comes in, it basically binds and interrupts this ligand or this combined estrogen receptor, and basically prevents it from binding to this strand of DNA, as well as it actually causes the degradation or destruction of it. And tamoxifen actually works. Tamoxifen, that I think a lot of you are familiar with, actually works in a similar way. And whereas the aromatase inhibitor is really such as Arimidex or anastrozole, letrozole, or exemestane, it works just by decreasing the estrogen production in a postmenopausal woman. So that's how that works. So when we combine a CDK4/6 inhibitor, it's kind of a double hit. And here you see the cell cycle. And basically what this represents is every cancer cell goes through kind of an evolution where it starts off not dividing, it reproduces its DNA, it separates its DNA, its chromosomes, and then it enters into its division phase or mitosis. And there's this whole cascade of protein signaling that allows this to go on. And these aromatase, or rather these CDK4/6 inhibitor, basically come and create this inactive dephosphorylated combined molecule that prevents this from being released, this E2F molecule from being released and being a driver of this cycle. So again, we're hitting it at the estrogen receptor interaction. We're also hitting it at the actual cell cycle itself. So this is, for instance, a major way in which we can treat bone-only disease, because again, the majority of bone-only disease is of this nature. So, and again, these are some of the other drugs, what we call osteoclast inhibitors. You can see them right here. Denosumab, or Xgeva, is an antibody that basically comes along and binds to one of these proteins involved in this vicious cycle that prevents it from basically allowing osteoclast precursors to become mature osteoclasts. And another common osteoclast inhibitor we use are bisphosphonates. And these are basically molecules that resemble pyrophosphate that's normally seen in the bone, but they're slightly different. They have a carbon molecule, or a carbon atom instead. And it basically gets taken up by the activated osteoclast and triggers auto death of the osteoclast. These are the two most common drugs we use. The what's called the RAKE ligand inhibitor, or denosumab, Xgeva, as well as the bisphosphonate, which we use primarily zoledronic acid in this country. And so patients who have bone disease are receiving one or the other. And basically, the denosumab is a monthly injection, similar side effects to the zoledronic acid that's given as a 15-minute infusion. And these infections tend to be, it can lower the blood calcium. It can also cause osteonecrosis of the jaw, which I'll mention. And there's a slight increased risk of infection. The zoledronic acid that we've had for a longer period of time, again, 15-minute infusion. Side effects, like what I've mentioned, although it can also cause kidney dysfunction in some patients. It can also cause a flu-like syndrome in patients, which I hear about a lot. Patients can have aches and fever for days to sometimes weeks. So that's one drawback to the zoledronic acid. So, and again, I think I skipped one here. So one question is, well, let me just say, what do we do to kind of mitigate against the potential side effects? Preventive dentistry. Osteonecrosis of the jaw, which here's a picture of, is a complication from either of these drugs that some of you have heard about. The risk is overall, I would say, low. Some studies have shown that over a 4-year period of time, the risk is about 4%. And when we look at the benefit, which can be a 22% decreased risk of pathologic fracture, we tend to feel that the risk of this is small enough. But again, we encourage preventative dentistry. Any teeth that need to be extracted, have that extracted, allow for healing before starting these medicines preferably. And then the oncologist should follow up the oral health as well while on treatment. And dental procedures should be avoided in terms of extractions, implants, while on one of these medicines. And it's also important to maintain calcium and vitamin D if you're on one of these medicines also. 1,000 milligram of calcium and 800 to 1,200 units of vitamin D is recommended. And so which one's better? So there was one large meta-analysis looking at 3 studies, and the denosumab, Xgeva, outperformed the zoledronic acid by delaying the time to that first skeletal-related event, 26.6 versus 19.4 months. And it basically also reduced the risk of a first SRE by 17%. So for that reason, probably the majority of us are using this. However, I would say the two medicines are highly comparable. There was no difference in survival when looking at these large studies. And the osteonecrosis of the jaw rate, which is what we're most concerned about, is equal for both. Getting into surgery, as I mentioned, surgical intervention is really crucial. We should always have a orthopedic or neurosurgeon involved if we have any concern about an impending pathologic fracture. And again, when we talk about spine in particular, here we see what's called a burst fracture. So just like with some patients who undergo a car accident, where you basically lose integrity, cortical integrity of the bone, we can see this in breast cancer as well. And so, indications for decompression and stabilization. Obviously, if there's spinal cord compression, if there's spine instability, and then in addition, what can be done, assuming we don't have this type of situation, but we have really replaced bone and we're worried about an impending vertebral fracture, we can do something like vertebroplasty, which is injecting cement into the bone. Are we doing okay on time, by the way? Stop. I see a stop. So that means no. Okay.